This video discusses respiratory failure and focuses on related nursing and collaborative care. So you can see the learning outcomes here. We'll be focusing on what a patient with respiratory failure might look like, and then what that nurse and the general healthcare team can do for these patients. So just to review, respiratory failure can be categorized as hypoxemic respiratory failure when the PaO2 drops below 60, and it can be due to a number of potential causes such as VQ mismatch as well as different causes of diffusion limitation. And we can also have hypercapnic respiratory failure, and that really isolates the failure of ventilation, such as airway patency issues, issues with respiratory drive, problems with chest expansion. And due to that failure of ventilation, the carbon dioxide is being retained and it goes above 50 and then causes acidosis. So now we're going to move into clinical manifestations. What will these individuals look like when they're in respiratory failure? And as you can imagine, someone may look different depending on comorbidities, other illnesses or diseases affecting them. But our patients will also look different as respiratory failure progresses. Someone who is just starting to develop respiratory failure will look very different from someone who has advanced to severe respiratory failure and has been in respiratory failure for a while. Also, a patient's ability to compensate can affect how a patient presents. So as you can imagine, it's important that nurses can catch serious problems early before they become more serious or irreversible or even fatal problems. And you'll see this as a common theme throughout nursing in general. Early detection saves lives, prevents complications, shortens hospital stays, etc. It's so important that we know how to assess a patient thoroughly and thoughtfully, and that we understand what we're looking at. So with that, what will these patients with respiratory failure look like early on? What are some of the first signs that we're going to see? One of the major signs that a patient is developing respiratory failure early on is a change in mental status. Now, seeing this on the slide, that makes sense. Hearing me say that makes sense. But when you see it, it may not be so obvious. For example, a patient starts to try to get out of bed and seems confused. Maybe they pulled out their IV or they pulled off their telemetry electrodes. They become agitated or even combative. Sometimes when you're faced with a patient who is behaving this way, the first thing that comes to mind is not early signs of respiratory failure. We might be frustrated or annoyed, but we have to think there is an underlying cause for this. So if a patient starts to get confused or restless or even just more fatigued than normal, these can be key signs that the patient is in respiratory failure. Now, along with those changes, our patients may also become anxious. This is their body sensing something is wrong. Their sympathetic nervous system has kicked in, and that anxiety might be paired with some mild hypertension, tachycardia, tachypnea. And also, if patients present with a headache in the morning, this could be due to a ventilation issue where they're not effectively removing enough carbon dioxide. So take a look at these. Nurses that can catch these early signs of respiratory failure can make a significant impact on the outcomes for these patients. This is why early and frequent assessments are so important. Now, as respiratory failure progresses, we may start to see additional signs and symptoms in our patients. So rather than memorizing a list of clinical manifestations, just try to think about why a patient might present in a certain way. So let's take a second to wrap our heads around what this patient is going through. They are having a very hard time breathing, to oversimplify things. So as we know, their body often triggers a sympathetic nervous response. And this can continue past the early stage and continue to cause tachycardia, tachypnea, hypertension, which could also result in a bounding pulse. The sympathetic nervous system also causes shunting of blood from the periphery to the core, some vasoconstriction in the periphery. And this fight or flight response tells the body to prioritize the most important organs in the center of the body, and we start sacrificing blood flow to the peripheral tissues. So we start to see cool, clammy skin. And when we're assessing that skin, we notice they also might be a little sweaty, a little diaphoretic. And this makes sense because our patients are essentially working out right now. They are using all of this effort just to breathe. Now next, a patient in respiratory failure, especially someone who is past the early stages of respiratory failure, is not going to breathe normally. And often their respiratory pattern is shallow and labored, and patients with tachypnea are breathing quickly because their body senses that there is too much carbon dioxide buildup and they're trying to blow it off. And we see patients using accessory muscles as well. They have to use muscles like their sternocleidomastoid to make the chest cavity bigger to bring air in. So they're using accessory muscles, but they're also tired. And one thing that can help make this a little easier on them is this tripod positioning. They may also have nasal flaring to try to bring in as much air as possible, and pursed lip breathing, which can actually help keep some pressure in the lungs to keep them open. So those are all of the things our patient is doing to try to help themselves. Now, the other signs that we see in our patient are basically the result of just not getting enough oxygen. So this is where we see fatigue and muscle weakness and even an inability to speak in full sentences. Your patient looks exhausted. They might not even be making eye contact with you. They might just be staring off into space. They might just be focused on one spot because, again, they're just trying to breathe. And if you ask them a question, they may have to catch their breath mid-sentence, or even in severe cases, you might just get one-word answers, like you ask how they are and they just say, "I'm exhausted," and that's all that they can get out. Now, when we're looking at these more ominous manifestations of respiratory failure that are in the late or more severe respiratory failure, their breathing pattern has gone from maybe a little labored or shallow to paradoxical. And paradoxical breathing means that instead of the belly and chest going out with inhalation, it actually goes in with inhalation. And this is just a sign of maximum use of those accessory muscles. They are really trying to work hard to open up that chest cavity. Also possible in late respiratory failure now, our patient has possibly lost consciousness. They could be comatose. Their blood pressure has now dropped. That lack of oxygen has started to affect their heart, and we might see dysrhythmias. So, for example, we might see bradycardias that often occur with severe hypoxemia. And as respiratory failure progresses, we now start to see it affecting the brain, which really likes oxygen. The brain starts to suffer, and our patient might present with seizures. Sustained hypoxemia is also going to start to show up on our patient's skin. So where they may go from pale to actually cyanotic, which you can see here. But this is definitely a late sign of respiratory failure. Now, we've talked about how important it is to do thoughtful and frequent informed assessments on our patients in respiratory failure, or even at risk for respiratory failure. So a little review here of what we're hearing when we auscultate the lungs. Remember, auscultating crackles means you're listening to fluid kind of bubbling. So this could mean your patient has pulmonary edema. And if they're really loud crackles, or what we would call coarse crackles, that can be because of pneumonia. Next, absent or diminished breath sounds. So if I'm listening to lungs and let's say on one side I hear and on the other side I hear, that would be diminished. So it's quieter. Or if I can't hear anything, that would just be absent. And basically our patient is not ventilating effectively if I hear these. So this could mean we have atelectasis, a pleural effusion, or maybe hypoventilation. Sometimes my patient just isn't able to take good effective breaths, so it sounds very quiet when I listen to them. Next, if we hear bronchial breath sounds, those really loud sounds we're supposed to hear over the trachea, for example, if we hear those loud sounds in the periphery of the lungs, that often means we have consolidation in the lungs, potentially from a pneumonia, because lung tissue that was supposed to be filled with air is actually filled with liquid, and there's also swelling or maybe hardening of that normal soft lung tissue. And then last, if you hear a pleural friction rub, so that kind of grating or almost squeaking sound of the pleural linings rubbing together, this may also happen in a patient with pneumonia that involves the pleura. Remember, normally these two pleural linings glide past one another because they are adequately lubricated. And in the case of pneumonia involving the pleura, those can lose the lubrication and cause that pleural friction rub. So we should have a pretty good idea of how respiratory failure can be a failure of oxygenation and or a failure of ventilation. And some of the numbers we're looking at, as well as how our patient may look from early on with some restlessness, for example, all the way to late clinical manifestations where they could become comatose or cyanotic or hypotensive. And we've had a quick review of our lung sounds and what they mean. But when we take care of someone with respiratory failure, what are we trying to accomplish? What are our end goals, and what are our goals while we're taking care of them? Well, the overall goal is really to correct any hypoxemia. We need them to get oxygen to their tissues. So in order to do this, we need to maintain a patent open airway, whether that's the patient doing this on their own or with some support or placing an artificial airway. We also need to make sure that the oxygen we're giving them is given to them in an optimal way. This can be as simple as sitting up a patient who has signs of respiratory distress, but can also involve selecting the best oxygen delivery device. And as we're optimally delivering that oxygen, we want to make sure our patient can tolerate that device. So this mask you see here might be tolerable for some patients, but it might cause anxiety or claustrophobia in others. Remember, just because we have a way to help our patients, it may not be tolerated or it may not be ideal for every patient. We also need to minimize oxygen demand. Our patient is already working very hard to breathe. They're demanding oxygen already. So we don't want them to be anxious. We want to limit physical effort and metabolic demand, which could start to use up the oxygen we're working so hard to deliver to that patient. And obviously, we don't want to just take a patchwork approach and address symptoms as they arise. We need to also consider why this patient has respiratory failure in the first place. So in addition to our immediate care, we need to be treating the underlying cause of this respiratory failure. And as you can imagine, our treatments for a patient with respiratory failure can be intense, and complications of respiratory failure can also be intense. As we take care of these patients, we want to prevent all of those potential complications. These could be complications from immobility, that resting in bed that minimized oxygen demand, that could increase risk for skin breakdown and thrombosis. These could be complications from big, bulky masks pushing on their face, or that endotracheal tube that was pushed into their airway. These could also be complications from hypoxemia, such as organ damage and tissue ischemia. We want to involve the patient as much as is safe and feasible, having them work to prevent complications as well, such as incentive spirometry when possible, and getting optimal hydration and nutrition in our patients. So, as you provide care for a patient with respiratory failure, certain diagnostic studies are often used to evaluate our patient's progress, their tissue perfusion, their response to care, and determine their plan of care. Our nursing assessment is also paramount during the course of respiratory failure, so I cannot underestimate the importance of frequent and early physical assessments. Our patients will often have chest x-rays, which can help in evaluating pneumonias and atelectasis, for example, arterial blood gases to help determine oxygenation and ventilation, as well as acid-base balance. Complete blood counts may be drawn and sent to the lab to evaluate for anemia and possibly leukocytosis indicating infection, and electrocardiograms may be done to evaluate for dysrhythmias that can potentially be complications of or complicate respiratory failure. Sputum and blood cultures may be sent to the lab to evaluate for possible infection, either in the lungs or systemically. And keep in mind there are many other procedures and diagnostic tests that could be included in the plan of care, such as evaluating serum electrolytes, CT scans, something called a VQ scan, where perfusion and ventilation are evaluated and can help identify if there's a pulmonary embolism, for example. Also, end-tidal carbon dioxide monitoring, also known as capnography, can help us evaluate the patient's ventilation. Now, in addition to these ways we evaluate how the patient's doing, some of our collaborative care also relates to how we treat the respiratory failure. The most obvious and most common is oxygen delivery and ventilatory support. Again, however we support our patient to meet their oxygen demands needs to be tolerable for the patient, and sometimes this means sedating them if the intervention is invasive. Now, we also want to make sure that we are giving the lowest possible oxygen concentration, the lowest FiO2, to meet the patient-specific goals. It is possible to give too much oxygen and cause oxygen toxicity, so we need to keep this in mind. How that oxygen is delivered could be non-invasive or invasive, and our non-invasive methods would be devices like a nasal cannula, a simple mask, Venturi mask, non-rebreather mask, CPAP, or BiPAP. Those don't require putting anything inside our patient. It doesn't mean they still can't bother them, so it's important to take that into consideration. Now, the invasive devices go inside the trachea, either through the mouth with an endotracheal tube or percutaneously through the anterior neck, which would be a tracheostomy. Now, we should be well aware at this point that oxygenation is not the same as ventilation. Some devices can help with both, and some can't. So, for example, a nasal cannula is a great way to deliver oxygen, but it's not helping our patient ventilate. It's not helping their lungs open more. It's not pushing that oxygen in per se. Yes, it is at a flow rate, but there's no way that that flow rate coming in from the nasal cannula would ever be forceful enough to literally inflate someone's lungs. And this is the same case with our simple mask, our venti mask, and even our non-rebreather mask. However, the CPAP and BiPAP deliver oxygen with positive pressure. These devices push oxygen into the patient's lungs so they can help with ventilation. And when an endotracheal tube or a tracheostomy is hooked up to the mechanical ventilator, those devices are also ways that we can support ventilation. Now, our patients with respiratory failure may receive a number of different medications to help treat symptoms of respiratory failure or maybe even the causes of respiratory failure. So, bronchospasms can be treated with bronchodilators such as albuterol, and corticosteroids like methylprednisolone, for example, might be prescribed to address issues of airway inflammation. Patients with excess fluid on their lungs and have pulmonary congestion may receive diuretics so that the fluid is urinated off. And if there is fluid backing up to the lungs because of left-sided heart failure, that patient might receive nitrates. Just keep in mind, these drugs come with a number of side effects and possible complications like hypotension, for example. So we need to keep a close eye on our patient before, during, and after administration. Now, if our patient has pulmonary infections, a variety of antibiotics such as azithromycin or ceftriaxone might be prescribed and will be typically administered IV. And as we mentioned in our goals of care, we want to minimize oxygen demand. And modifiable sources of oxygen demand are anxiety, agitation, and pain. So providing relief of pain with opioids or even non-pharmacological interventions and addressing anxiety with benzodiazepines is also appropriate. Now, we're seeing more and more use of dexmedetomidine or Precedex in patients who have anxiety and respiratory failure because it can reduce anxiety without knocking out our patient's respiratory drive, unlike some benzodiazepines. Now, just remember, if your patient is experiencing pain, anxiety, or agitation, we need to do a thorough assessment of why before we simply medicate them.